Hello everyone, thank you for joining me today. My name is Joy Ruhigisha and I'm a PsyD student at the California Southern University. Today I will be exploring the important role that emotion and motivation play in panic disorder, one of the most common and disruptive anxiety disorders. Panic disorder is more than just experiencing fear. It involves intense emotional, physiological, and behavioral responses that can deeply impact a person's daily functioning and quality of life. Here, my second slide has like the layout of all my slides. So we're going to have the introduction, the physiological processes in the panic disorder, sympathetic and parasympathetic nervous systems. We will explore neurotransmitters and hormones in panic disorders. We'll talk about a little bit about fight, flight, freeze responses, causes of panic disorder, comorbidities, evidence-based therapeutic treatments. We'll explore medications or pharmacological treatments, therapeutic techniques, supports that are needed, and also cultural consideration. So I will start off this presentation with one of my favorite quotes that pertain to panic disorder by Barlow, which states that panic disorder is maintained not only by heightened fear responses, but also by motivational tendencies towards avoidance driven by emotional deregulation. The definition and the DSM-5 criterion prevalence. So first of all, panic disorder is a serious and often debilitating anxiety disorder characterized by sudden, intense episodes of fear known as a panic attack or panic attacks. According to the DSM-5, a person must experience recurrent and unexpected panic attacks, followed by at least 1 month of persistent concern about having more attacks, or significant behavior changes aimed at avoiding future episodes. These changes may include avoiding public places, exercise, or even certain thoughts that trigger symptoms. The condition affects around 2 to 3% of adults each year, and it often emerges in late adolescence or even early adulthood. It is more common in women than in men. When we look at panic disorder through the lens of emotion and motivation, we find that it is deeply tied to how people interpret and regulate internal experiences. Individuals with panic disorders often experience emotional dysregulation, meaning they struggle to manage the overwhelming fear and physiological arousal that accompanies panic. This leads to motivational patterns focused on avoidance, avoiding bodily sensations like increased heart rate or shortness of breath, and avoiding environments associated with previous attacks, such as crowded spaces or exercise. Understanding this emotional and motivational framework is essential when designing effective interventions. It is not just about treating symptoms. It is about helping the individual regain a sense of control over their emotional responses and breaking the cycle of avoidance that maintains the disorder. To understand panic disorder, we need to look at the physiological processes that drive the intense symptoms people experience during a panic attack. First is the autonomic arousal. During a panic attack, the body's sympathetic nervous system kicks into overdrive. This leads to rapid heartbeat, shortness of breath, dizziness, sweating, and chest pain, symptoms that mimic a medical emergency, which in turn fuels the panic. This arousal is not in proportion to any real external threats, but the body reacts as if it were. A key brain structure involved in this is the amygdala. It plays a central role in processing fear and initiating a fight or flight response. In individuals with panic disorder, the amygdala is often hyperactive, reacting strongly to internal cues like changes in breath or heart rate, even if there's no actual danger. Another important system is the HPA axis. This governs the body longer-term stress response by releasing cortisol. In panic disorder, the HPA axis may be dysregulated. resulting in excessive release of stress hormones that maintain a heightened state of anxiety and physiological arousal. According to Gorman and colleagues, these systems, the autonomic neuroendocrine and the limbic, form an interconnected fear network. In panic disorder, this network becomes hypersensitive, responding inappropriately to perceived threats and reinforcing the cycle of panic. A key physiological mechanism behind panic disorder involves two branches of the autonomic nervous system. This is the sympathetic and the parasympathetic systems. The sympathetic nervous system, or the SNS, is responsible for triggering the fight or flight response. When activated, it causes the heart rate to increase, the pupils will dilate, and the digestion to slow down, all in preparation to respond to a threat. This system is designed to be temporary and adaptive to the face of the real danger. On the other hand, the parasympathetic nervous system, or the PNS, is what helps the body relax and return to a state of balance. It promotes the rest and digest response, slowing heart rate, reducing blood pressure, and calming the body after a stressful event. In individuals with panic disorder, this balance between the SNS and the PNS becomes dysregulated. The sympathetic system activates too easily, often in response to harmless cues like a faster heartbeat. Meanwhile, the parasympathetic system may be slow to respond, leading to prolonged arousal and anxiety even after the threat has passed. According to Thayer and Lane, this imbalance is in autonomic control, what they call impaired neurovisceral integration, is a core physiological marker of anxiety disorder, including panic disorder. Therapeutic interventions like breathing, retraining, and biofeedback often aim to strengthen the parasympathetic regulation. Neurotransmitters and hormones play a major role in panic disorder by influencing how the brain and the body respond to perceived threats. Let's take a look at the most important chemical messengers involved. The first one is what we call the NE. This neurotransmitter is responsible for increasing alertness and triggering the physical symptoms of panic, like rapid heartbeat, heightened blood pressure, and such. Charney and his colleagues found that individuals with panic disorder have an exaggerated noradrenergic response, meaning their fight or flight system is hyperactive. Serotonin, or 5-HT, is another key player. It helps regulate mood, fear responses, and emotional balance. Dysregulation in serotonin pathways has been linked to both anxiety and panic. That is why many pharmacological treatments for panic disorder, such as SSRI, target serotonin. GABA, or gamma-aminobutyric acid, is the brain's primary inhibitory neurotransmitter. It works like a brake system, helping to slow down neuroactivity and reduce anxiety. In people with panic disorder, GABA function is often impaired, leading to reduced ability to turn off the alarm response once it's being triggered. This contributes to the lingering feeling of fear and loss of control during panic attacks. Finally, there is cortisol, the body's main stress hormone, released through the HPA axis. While cortisol is helpful in short bursts, chronic overactivation of the HPA axis can lead to excessive arousal and vulnerability to anxiety and panic. These chemical imbalances not only contribute to the onset and maintenance of panic attacks, but they also guide treatment choices, whether pharmacological or therapeutic. Okay. Okay, the fight-flight-freeze response in panic disorders. One of the most fundamental survival responses we have is the fight, flight, or freeze reaction. It's our body's rapid automatic reaction to danger, and it plays a central role in panic disorder. The fight response prepares us to face a threat directly through confrontation or aggression. This may look like shouting, flailing, or a surge of physical tension. The flight response drives us to get away from the danger, fleeing the situation entirely. People experiencing panic may run from a crowded room, leave a conversation abruptly, or avoid certain places altogether. The freeze response is more passive. It involves immobility, both physical and cognitive. In panic attacks, this might manifest as being unable to move, speak, or think clearly. The body shuts down in an effort to stay undetected or emotionally safe. Importantly, these responses are triggered by perceived threats, not always real ones. In panic disorder, the brain misinterprets harmless bodily sensations like a racing heart or a shallow breath as signs of imminent danger, activating this survival system inappropriately. Kozlowska and his colleagues described these responses as part of an integrated brain-body defense system. In panic disorders, this system becomes overly sensitive and poorly regulated, leading to intense and often controllable fear responses even in safe environments. Now, understanding how these responses function is essential for both clients and clinicians as treatment often focuses on retraining the brain and the body to respond more accurately and calmly. What are some of the causes of panic disorder? Panic disorder is understood to result from an interaction of biological, psychological, and environmental factors. Biologically, individuals with panic disorders often have a genetic predisposition with higher concordance rates observed among first-degree relatives. Neuroimaging studies have also shown functional abnormalities in areas like the amygdala, which governs fear, and the prefrontal cortex, which normally helps regulate emotional responses. Battaglia and colleagues argue that these inherited traits may create a heightened baseline vulnerability to panic and stress. Psychologically, panic disorder is closely tied to catastrophic thinking, misinterpreting harmless physical sensations like a rapid heartbeat as signs of heart attack or death. This reflects high introspective sensitivity, meaning the person is acutely aware of internal bodily changes and more likely to mislabel them as dangerous. Environmental factors also play a significant role. Many individuals with panic disorders report a history of early trauma, including neglect, loss, or emotional unpredictability during childhood. These experiences may condition the brain to expect threat, contributing to the chronic overactivation of the fear circuits later in life. Importantly, no single cause explains all cases. Panic disorders emerges from the interaction of genetic risk, cognitive style, and lived experiences, which is why a multidimensional treatment approach is often necessary. Comorbidities in panic disorders. Panic disorders rarely present in isolation. According to Kessler and colleagues, individuals diagnosed with panic disorder frequently experience comorbid psychiatric conditions which significantly complicate both diagnosis and treatment. The most common comorbidities include generalized anxiety disorder and major depression disorder. These conditions often share underlying cognitive vulnerabilities such as negative affectivity and emotion dysregulation, which contribute to a more persistent and treatment-resistant course. In particular, comorbid depression may reduce energy, hope, and motivation to engage in therapy, while the GAD adds a layer of chronic worry that can mask or intensify panic symptoms. Agoraphobia is also strongly linked to panic disorder. While panic attacks are often acute and episodic, agoraphobia reflects avoidance of places where escape might be difficult. This comorbidity tends to reinforce behavior avoidance, making exposure-based treatments more challenging to implement. Lastly, but certainly not least, substance use disorders are prevalent among individuals with panic disorders, as many turn to alcohol and benzodiazepines in an attempt to self-medicate. This can create a cycle of dependency that further hinders treatment, engagement, and long-term recovery. The presence of comorbidities highlights the need of integrated multimodal treatment approaches that address both panic symptoms and the broad emotional or behavioral patterns that sustain them. Best treatment for panic disorder. Among psychological treatments, CBT, or the cognitive behavior therapy, remains the most empirically supported intervention for panic disorder. CBT addresses both cognitive distortions, such as catastrophic interpretation of bodily sensations, and the behavioral avoidance patterns that maintain the panic cycle. Some of the key components of CBT include psychoeducation, which essentially helps clients to understand the physiology of fear and panic. Also introspective exposure, where individuals are guided to intentionally provoke and tolerate feared bodily sensations like rapid breathing or dizziness. Last but not least is cognitive restructuring, which involves identifying and modifying irrational beliefs about these sensations. Another evidence-based treatment is a specialized form of CBT known as the PCT, emphasizes breathing retraining, self-monitoring, and graduated exposure to triggers. PCT is particularly effective in reducing the anticipatory anxiety that precedes panic attacks. However, in recent years, there is another evidence-based treatment called mindfulness cognitive therapy, which has gained traction as an evidence-based treatment. MBCT incorporates mindful practices into CBT framework, helping clients become more aware of panic-related thoughts and sensation without judgment. This reduces emotional reactivity and improves long-term resilience. Overall, these interventions not only reduce symptoms like the frequency and severity of symptoms, but also enhances clients' motivation and confidence in managing their physiology and emotional response. Pharmacological treatments for panic disorder. Pharmacotherapy is often used alongside psychotherapy in the treatment of panic disorder, particularly in moderate to severe cases. According to Baldwin and his colleagues, the SSRIs are considered the first-line pharmacological treatment. Medications like fluoxetine and sertraline work by increasing serotonin availability in synaptic clefts, which helps regulate mood and reduce the neurobiological reactivity to stress. SSRIs are effective in decreasing both the frequency and intensity of panic attacks and generally well tolerated. On the other hand, the SNRIs, such as venlafaxine, offer a viable alternative, particularly in patients who also experience GAD or depressive symptoms. These medications enhance both serotonin and norepinephrine transmission, targeting overlapping transmitter systems involved in the stress response. Benzodiazepines, including alprazolam and clonazepam, can offer immediate relief from acute panic symptoms. However, their use is limited due to the risk of tolerance, dependency, and withdrawal. As such, they are generally prescribed for short-term use or an adjacent while waiting for SSRIs or SNRIs to take effect, which may require several weeks. Importantly, medication selection should be tailored to the individual, considering factors such as comorbid conditions, prior treatment history, and tolerability. Therapeutic techniques supporting panic disorder treatments. Beyond structured CBT protocols, several adjunctive therapeutic techniques are particularly effective for individuals with panic disorder, especially when comorbidities or emotional dysregulation are present. Motivational interviewing, MI, is a client-centered directive technique that fosters intrinsic motivation for behavior change. It is especially helpful when clients exhibit ambivalence towards treatment or when substance use co-occurs with panic disorder. MI helps clients resolve internal conflicts, enhance commitment, and engage more fully in the therapeutic process. Emotional regulation training, often derived from dialectical behavior therapy, DBT, is another essential approach. Panic disorder is frequently maintained by emotional avoidance and reactivity. So training clients to recognize, label, and tolerate intense emotions reduces reliance on maladaptive coping mechanisms. Lenahan emphasizes the importance of emotional acceptance and skill building in achieving psychological stability. Finally, biofeedback and breathing retraining, targeting the physiological core of panic attacks. Morit demonstrated that capnometry-assisted respiratory training can normalize breathing patterns and reduce hypersensitivity to bodily cues. These techniques increase clients' sense of control over their physiological responses, breaking the fear symptom cycle. These methods are particularly valuable when integrated into a comprehensive multi-modal treatment plan tailored to individual client needs. Support needs in treating panic disorder. Support system plays a critical yet often underemphasized role in the effective treatment of panic disorders. According to Barlow, social support is a key moderator of treatment success. Individuals who feel emotionally supported by friends, family, or peer networks are better able to engage with exposure exercises, tolerate discomfort, and maintain motivation over time. Family therapy can also be instrumental, particularly when misunderstandings or stigma surrounding panic symptoms are present. By involving family members in the treatment process, clinicians can normalize the experience, educate others on how to respond supportively, and reduce unintentional reinforcement of avoidance behaviors. Psychoeducation for both clients and their families lays the foundation for recovery. Understanding the neurobiological and cognitive roots of panic reduces fear and confusion, fostering a sense of agency in managing symptoms. Finally, clinicians must attend to motivational factors. Panic disorders often involves avoidance, ambivalence, and hopelessness. Building intrinsic motivation by aligning treatment with personal values and goals can significantly enhance engagement, especially in long-term or relapse-prone cases. Together, these support elements promote holistic, sustainable recovery, particularly when integrated in a broader therapeutic framework. Culture consideration in panic disorder treatment. Culture plays a fundamental role in how individuals experience, interpret, and respond to panic symptoms. According to Hinton and colleagues, culture groups often somatize emotional distress, expressing it through bodily symptoms like chest tightness or dizziness, which can delay diagnosis or lead to misinterpretation in Western medical models. For example, with the Atlantic's population, panic symptoms may be labeled as ataque de nervos, a culturally recognized syndrome marked by uncontrollable crying, trembling, or aggression, often linked to familial or social stress. Asian American clients may minimize emotional disclosure to preserve familial harmony or avoid stigma, while refugee groups may carry trauma histories that shape panic expression through hyperarousal or dissociation. These variations require adaptation of treatment protocols, including language-congruent interventions, use of culturally resonant examples, and greater attention to community norms and spiritual beliefs. As Sue and Sue emphasize, culture competence, including awareness of one's own biases and respectful attunement to cultural identity, is crucial for building therapeutic alliance and improving outcomes. In practice, this might mean modifying CBT techniques to incorporate collectivist values, involving family members in treatment planning, or integrating traditional healing frameworks when appropriate. In summary, addressing culture isn't an add-on, it is an ethical and clinical imperative in effective panic disorder treatments. In conclusion, emotion and motivation are not peripheral to panic disorder. They are central to both its experience and its treatment. Dysregulated emotional responses and maladaptive motivational patterns like avoidance or fear of sensations form the core of panic attacks, and addressing them directly is key to long-term recovery. We have also seen that effective intervention must be biopsychosocial, targeting neurochemical imbalances, cognitive distortions, emotional dysregulation, and environmental contributors. Moreover, as demonstrated by research from Hinton, Su, and others, social culture context deeply influences symptom expression, treatment, engagement, and outcomes. Therefore, it is critically important that clinicians must be prepared to adapt interventions not only to the disorder, but to the person, considering their biological predispositions, psychological makeup, and cultural background. This is where early identification, trauma-informed care, and cultural humility become extremely essential. Finally, I encourage all mental health professionals to promote awareness, challenge stigma, and advocate for accessible, culturally responsive care, ensuring that all individuals with panic disorder receive treatment that is not only effective, but affirming and inclusive. Thank you for tuning in. This is the end.